Hello and welcome to a presentation on squats and patella tendinopathy. So the objectives for today were to have an understanding of the terminology of squats, an overall view of the basic assessment of squats and guidance of the correct technique, a summary of some of the past studies of squats and patella tendinopathy. If you want to, you can use this presentation and complete practical elements by the side of the sort of PowerPoint review, and obviously a patella tendinopathy review, the etiology, risk factors and clinical tests, and I won't have included the review of case studies in this. There is a list of references at the end, but you can add your own example case studies if you want to. So with the introduction, the squat's widely regarded as one of the most effective exercises for improving strength and increasing athletic performance. So it's the focus of a large number of biological studies, and it is made up of a complex series of movement involving the torso and all the major joints of the lower limb. Obviously safe it is if it is performed correctly, and it's one of the most frequent exercises prescribed by physiotherapists, probably because it requires a large amount of control. An improper technique is the most important factor when contributing to injury. So the movement principle of a squat extends into later adult life, really when you're thinking about the continuation of independent living, and this rests on the ability to maintain strength and mobility and avoid injuries such as falling. Nearly all squats comprise a basic and fundamental blueprint that underlies the biomedical technique, and because of this, a large number of studies have been completed purely on this. The back squat, which is your basic squat, can be used as an assessment tool for neuromuscular control, strength, stability and mobility, and it forms part of dynamic control for most sports. So part one is the squat, and then part two will be the patella tendinopathy bit. So first of all, the squat. Types of squats are almost a complete language in themselves. So apart from the ones that are pictured here, there's other variations. So you've got a sumo squat where your stance is wider. Your basic traditional squat or back squat is your sort of parent technique of them all. And as I said, there's many different techniques. So the Anderson squat, for example, is where you place the barbell on a stand and you would start the squat or the explosive movement from underneath the barbell. So as stated before, the back squat is almost like the parent technique of all of the other squats. So it's one of the most efficient exercises to enhance performance, and it translates to improving quality of life in tasks such as lifting, carrying heavy objects, and at a very basic level, just your simple sit to stand. So from a neuromuscular control, you can look at the sort of coordination and recruitment of muscles throughout the technique. From a strength point of view, you can look at muscle weakness, sort of asymmetry or joint instability, and obviously from a mobility point of view, anything sort of tightness-wise that might be contributing to poor technique. So as stated at the bottom, it's highly sensitive to highlighting biomedical deficits, and obviously, just like diets would be, the squat should form the basis of a balanced program. So you'd never give anyone really just a squat, you would want to do it alongside other exercises as well. So for the basic squat assessment, you have a sort of summary of a setup really. So for the arm position, you'd hold a dowel or a pole in the back squat position with your forearms parallel to your torso and the upper back sort of muscular contracted. You want to grip the pole with a pronated grip slightly wider than shoulder width apart. The stick should be positioned across the posterior deltoids just below the C7 vertebrae, And perhaps you could also use a verbal cue to pull the bar into the trapeziuses, as this facilitates the back extensors and stiffens the torso. For your stance, feet are placed with heels shoulder width apart and toes forward and slightly outward to about 20 degrees. So also for the basic squat assessment, you want to give simple instructions. So an example is on the slide, which is please stand upright with feet shoulder width apart, squat down until you believe the tops of your thighs are parallel to the floor, and then return to the starting position. So for some people, that's too complicated a verbal cue, and to start off with, you'd just say something like, imagine you're sitting down on a chair and then come up again. So you can tailor that to the individual. So we'll go through the various different positions of a squat in parts of a body. The pictures on the slide will show you sort of correct and incorrect positions. So head position is very important because an incorrect head position may follow down the body and into improper spinal and trunk positions, and hence it'll be more vulnerable to injury. So with the technique, you want a neutral position. Simple verbal cues can be telling the person to gaze straight ahead or slightly upwards, and that helps prevent forwards trunk flexion. And then that's a summary of the common deficits that you get. As mentioned before, flexion can encourage thoracic flexion, although you might have someone who does it the other way, so they've got hyperextension of their neck. And again, you're looking at muscle stiffness, so if they're moving more with their neck, they might be very stiff in extension in their upper back. So usually if there's a deficit, there's a reason or something contributing to it. So there's various corrections and training techniques you can also do to correct the deficits. For the trunk position, again, the pictures will show you correct and incorrect technique. So you want to hold, again, it's better if you hold a pole because it encourages contraction of your back extensors. And you want the scapulars or shoulder blades retracted and depressed. Your glenohumeral joint or your shoulder joint should be externally rotated, and the screening for this, I suppose, would be primarily looking at it from the side. Again, you've got common deficits and corrections you can use to sort of correct some of these deficits as well. So with the torso positional deficits, stability here is derived from the core muscles like your quadratus lumborum, abdominals, etc. And individuals really need to show the ability to maintain a static torso with a neutral or lordotic lumbar position as a safe and optimal squat strategy. And really deficits include weakness of the thoracic and lumbar paraspinal muscles, and that would encourage too much flexion in the torso position. With your hip position, again, you're mainly looking at this from the side. And as mentioned previously, you need that sort of extension in your lumbar spine so your hips can get into the optimal position. With your hip position, common deficits would look sort of mediolateral rotation or unilateral drop-in on one side, increased lumbar flexion, and that might be a compensatory movement due to type hips even. So the line of the hip should be parallel to the ground, and the position of your femurs, your long leg bones, symmetrical throughout the movement. When you're screening someone, you want to look for the hips twisting, dropping, or leaning anteriorly or posteriorly. And the weaknesses might be due to muscular imbalance on one side or both sides. And again, the slide shows common deficits and corrections and training you can do to correct this. With your knee position, you're primarily screening this from the front, But again, really, you're looking for sort of excessive sort of medial or lateral movements, and you're ideally looking for symmetry with the knees over the toes, really, as a basic screening tool. So your valgus movement with the knees coming in tends to be more common than your varus movement. And again, nice simple slide showing deficits and common simple correction techniques you can do to correct this. So tibial femoral and patellofemoral compression has been shown to increase with increased knee angle as a protective function by co-contraction of the quads and the hamstrings. As mentioned before with your technique, your knee should track over the toes throughout the squat movement, and the lateral aspect of the knee shouldn't cross the medial malleolus and vice versa. With your valgus movement, that can be caused by weak hip muscles, or your varus movement, it's sometimes a compensatory strategy for flat feet. Mobility, really, you're looking at tightness, and tightness can encourage that inward and outward movement. So you want to look at the ankles and at the hips as well for any tightness that might be contributing towards it. As well as knee position, you've got your tibial translation angle. So really, that's your inward and outward rotation movement. And you want an adequate tibial translation angle. This is achieved via normal foot and ankle mobility. And as a general rule, the tibial angle should match the trunk angle. Reasons for excessive translation are weakness in your hamstrings, or quads dominance, or weakness in your calves. With mobility, tightness in your calves can be a reason, and also the ankle or talocrural joint, and also look again at your hip mobility and knee mobility. The next slide shows incorrect or correct foot position, and again, many of the contributors to this can be sort of tightness in your calves especially. Common defects include lifting your toes or heels off the ground, and again, a major reason for this is tightness in your ankle joint or the muscles of the lower leg. With your technique, your foot should be on the ground throughout the entire movement. So you want to suggest that pressure is from the midfoot initially to the heel and lateral foot during descent, and this is while keeping your toes on the ground. Placing weight through the lateral aspect of the foot can sometimes help you recruit the glutes in the hip. You can screen for foot position, of course, from anterior and lateral and posterior positions, whereas screening other parts of the body you would mainly do from the side. Mobility, as mentioned before, your tightness is almost always due to a tight calf with your gastrocnemiuses and soleus. So looking at your whole sort of descent in one go, there's a sort of correct technique and a fluid movement. So descending should involve a fluid coordination of movement of flexing the hips, knees and ankles, and should begin with hip flexion and a rigid torso. This initiates load to the lower limb and the posterior chain. So you want to descend as if sitting in a chair slightly too far away, an even tempo, and a ratio of 3:1 compared to the concentric ascent phase. Common defects would be your weight anteriorly on the knees, or a rapid or unsteady movement. So with neuromuscular control, you're looking at sort of knee loading instead of hip hinging. A strength and stability aspect would be a lack of lower limb eccentric control. The patient would be dropping rather than descending, and that's often seen in the older population who do a very quick movement downwards. With your mobility, often you're looking at a lack of lower limb mobility and tightness, and that would lead to your increase in spinal flexion. With your squat depth, you want to go down to about parallel, and with the incorrect picture, a lot of the reasons for not being able to go down lower are often due to tightness. There's evidence that a greater squat depth than parallel can do harm to any knee ligaments or menisci in the knee, and the parallel is also the most functional depth, because this is obviously the depth you'd sit on a chair. As pointers, you want your femurs parallel to the ground and your feet flat on the ground. And common defects is obviously not achieving your depth, a lack of sort of that posterior chain strength to maintain hold there can often contribute to not being able to get down as far. When you ascend back up, again the picture shows the difference between the correct and incorrect technique, and this can be due to sort of sort of hips rising faster than your shoulders or an excessive forward lean. It can be also, again, weakness in your posterior chain. So the technique really is having your weight on your heels and lateral sides of your feet. The hip primarily drives the ascent, and you want to exhale really sort of halfway up or fully up. So as mentioned before, verbal cues, you can keep them nice and simple, as you don't want to overload people with too many instructions. So as mentioned before, you can tell someone simply, descend while looking straight ahead or slightly up. And that would be a really simple way of doing it. Or you can focus on the individual parts, or simply say, imagine you're sitting down in a chair. If people really don't get the technique of a squat, you can always just obviously put a chair behind them and just ask them to sit down, and then ask them to do the same technique without the chair there. So moving on to studies. Studies are in the reference section at the end on the last slide, so I won't mention to start off with where they came from. So with this, they studied technique of people doing squats independently or with as you can see, a sort of wall in front of them, so their knees never came in front of their toes, which is considered correct technique. So previous studies prior to this noted that more successful lifters had less anterior knee displacement, and less successful lifters leaned forwards more. So the greatest torques for the knee occur in maximum knee flexion, as you would expect them to, and for the hip during the second half of the concentric phase even. The method was 7 men, average age 27, and they did a high bar parallel squat. And there were 3 restricted and 3 unrestricted squats performed. So the results were that they found a significant difference between the 2 squats. The restricted squat, which was the one with the wall in front of them, they had a more inclined torso and less knee and ankle flexion. And the more vertical lower limb is accompanied by a greater anterior lean of the torso. So you'd question whether is that reflective of a more skilled lifter. And the increased hip forces are transmitted into the lower back. And as mentioned before, the patellar compression forces increased with an increased knee angle. So the next study, that was a biomechanical comparison of the traditional squat, powerlifting squat and box squat. So the results obtained in this study discuss the fact that by restricting anterior displacement at the knee, you may be creating injury forces at the lumbar spine. Obviously, both the powerlifting squat and the box squat are popular exercises used by athletes other than weightlifters to develop strength and power. So in this study, the subjects were 12 people, average age 27, and minimum 3 years experience with weightlifting. They comprised of well-trained powerlifters with extensive experience of performing each exercise. There were 2 sessions separated by 1 week. Session 1 was in the gym using 1 repetition max. Session 2 was in the laboratory with speed repetitions of 30, 50 and 70% of their 1 repetition max. Analysis was in session 2 only. There were 5 maximum attempts between 2 to 4 minutes between each set was allowed. There was a warm-up which was 6 to 10 repetitions, which was 3 to 5 sets of less than 40% of their 1 repetition max. For the traditional squat, the knees were allowed to pass the toes. However, for the powerlifting and box squat, they were instructed to maintain as vertical shin as possible by moving the hip posteriorly. And during the box squats, a minimum of 1 second was allowed on the box. There were markers placed in this study on the 7th and 10th thoracic vertebrae, or I presume they mean the 3rd thoracic vertebrae, the suprasternal notch, the inferior tip of the xiphoid process, the bilateral anterior superior iliac spines, the bilateral femoral epicondyles, bilateral lateral malleolus, and midpoint between the posterior superior iliac spines, and bilateral midpoint, femur, tibia, and calcaneus. A motion analysis and a force platform were used for analysis as well. So the results were that there was greater posterior hip displacements and reduced anterior knee displacements during the powerlifting and box squats. The centre of mass displaced anteriorly in the traditional squat and posteriorly in the power and box squat, although this is probably due to the fact that in the power and box squats they're instructed to keep as vertical lower limb as possible. The hip had greater abduction angles, flexion and internal rotation in the powerlifting and the box squats, which traditionally have a wider stance than the traditional squat. And as mentioned in the 2 below, greater flexion angles at the knee and ankles during a traditional squat, and ankle flexion and hip flexion were decreased when the box was introduced. So really the discussion is about a narrow stance versus a wide stance. A wider stance produces increased hip flexion and smaller dorsiflexion and plantar flexions. Sort of analysis of the curves were consistent across all subjects with a traditional squat, simultaneous flexion and an extension of the hip and knee with increased range of movement at the knee joint. And the 2 points below you can read out yourselves, but that's more results from the study. And then from previous studies as well, so the largest peak movements were with a traditional squat with regards to L5 and S1 at the bottom of your back. So the advice was that keeping an upright torso was best with a wider stance. So really the stimulus of a squat can be altered just by employing different movement strategies. So for example, the powerlifting squat may be better for people with flexibility at the hip and decreased movement at the ankle. The powerlifting squat requires substantial mobility at the hip joint. So with physiotherapy, if you work in a hospital or in most settings, in the UK at least, most of the patient base may be older and not as fit or flexible. But obviously we can't assume everyone we see is going to be old or possibly infirm as well. The sets and reps debate is out and probably always will be, but for most people you're probably trying to build up conditioning rather than strength. So you'd want to aim sort of high reps with 2 or 3 sets, and just people can progress it by increasing their weight. So part 2 of this presentation is on patella tendinopathy, and really, so Patella tendinopathy is obviously the tendon just below your kneecap or the patella. There's a highest prevalence it's found is in volleyball players, really, which is about 44%, and then basketball, 36%. This is obviously from American studies, where basketball is obviously one of the major sports. So in other countries, such as the UK, this wouldn't be such a high percentage. So you might find, say, in New Zealand, for example, netball would be a lot higher in prevalence than patella tendinopathy. As with most tendinopathies, you're more likely to get it with a sort of drastic change in frequency or intensity of your training, and this is sort of exacerbated in sports where there's a lot of jumping and a lot of acceleration. With your physical examination of patella tendinopathy, there'll be pain over the inferior pole of the patella and possibly in the body of the tendon as well. Thickness of the tendon may be noted. Usually there's no swelling or effusion, and the pain can sometimes be reproduced on resisted knee extension. Many treatment protocols are derived from evidence about other tendinopathies in the body and applied to the patella tendon. So really eccentric exercises, in studies at least, were first introduced around the early 80s for tendinopathy. The graph on the right of this slide is from a sort of recent study in the past 10 years, which shows that tendons can go from sort of a normal tendon to a reactive tendon to tendon disrepair and degenerative, but they can go back again to a normal tendon. And the pain really that people get really appears independent to whatever the tendon pathology is at the time. There was a study done on basketball players, again in the USA, who were ultrasounded each month during the season, and those with reactive and disrepair of their tendon, they progressed to degenerative and regressed to normal tendon. So tendons can change throughout the sort of season. As underlined here, overload is a key factor associated with the onset of that. And overload is defined as an activity above which the tendon has adapted to at that point in time. So it's often by a sudden increase in training and return, say, from a holiday, and without a gradual return to regular training. So you've got extrinsic, sorry if I can pronounce it correctly, and intrinsic factors, so that may contribute towards it. So the increase in training volume and frequency, that's been confirmed in several studies, and really clinically it's the most common factor that will trigger patella tendinopathy, or most tendinopathies really. In BMI, to be exact, those with a waist greater than 83 centimetres were more likely to have abnormal changes of imaging, and also reduced ankle dorsiflexion, and also patella outer, or your patella sitting slightly higher than the average, also can contribute towards patella tendinopathy. The reason dorsiflexion at your ankle is crucial is because it absorbs most of the landing energy from jumping. Sorry, I meant to delete this slide. It was a case study that was for the presentation, but as mentioned at the beginning, you can put your own example case studies in if you want to, and feel free to use this presentation if you want to. So for treatment, it's recommended that eccentric squats or eccentric loading generally in patella tendinopathy. Often with research, it indicates other exercises alongside eccentric exercises. So most of the research is based on sort of the research that started off with tendinopathies, which is from Achilles tendinopathy really. And so If you're thinking, why do most studies recommend 15 repetitions with 3 sets once or twice a day? Most studies have simply copied the prescription from old Achilles tendinopathy studies. With progression, you could go from slow, pain-free jogging, resisted cycling, water exercises as well. It's difficult to know when to return to sport, but obviously when you do, you can do that in a limited way. And a lot of studies give different advice about when's the optimal time to return to play. You can also do sort of lowering off a step on the affected leg and introducing jumping activities. And they don't necessarily need to be sport specific, i.e. they're not really needed for runners with jumping exercises. And also using a decline board. A lot of studies recommend using that because it tends to isolate the knee more. So it also reduces calf muscle tension and it isolates the knee mechanics a lot better. The load on the patella tendon itself is maximized, and that's usually with an incline angle of 25 degrees. Also, the angles at the ankle and the hip are significantly reduced. So there was a small study done on 17 patients where the pain score decreased significantly in the decline group, but not in the standard group. And that was using 3 sets of 15 repetition twice daily for 12 weeks. And they weren't allowed to continue with their sports during the first 8 weeks. So only 1 in the standard group returned to pre-injury activity, and 6 in the decline group returned to pre-injury activity. Although it must be said, the study is very limited due to the low numbers. So for tests and interventions, you want to investigate the kinetic chain, perhaps assess using a single leg decline squat. On observation, you want to look for any wasting of the muscles or weakness in the quads and calves. Obviously check for dorsiflexion of the ankle to check for lack of flexibility. Subjective assessment is really important, so ask people about training changes they may have made recently. And obviously you want to take load off the tendon and allowing it to heal, so removing their high load drills, decrease frequency of training or the time or the volume of training, and really educate them about the condition. Tendinopathies can take a long time to heal, and you can do this alongside other modality. Obviously taping, while not being a solution, can certainly help with the healing process and can allow things to recover more quickly. So with a single leg decline squat, the pain should remain isolated to the tendon and not spread. The pain monitoring through this test is the best way to monitor the tendon's response to load. If it's a single leg problem but highly irritable, then bilateral exercise with a shorter holding time and fewer repetitions are recommended. Strengthen obviously where needed if there's a weakness. Training changes can be adapted without resorting to complete rest. So for example, cycling and swimming or aqua activities can maintain stamina yet unload the tendon. Education, obviously if a patient is being realistic about rehab times with training plans, that's better to introduce that at the beginning. Because overall, if someone's impatient with their rehab, it will create a poorer prognosis. So, in conclusion, even if most studies have deemed that eccentric training has a positive effect, our ability to specify which protocol component is responsible is limited. So certainly with patients that I've seen, simple squats and change in training will be the main 2 things that have helped. And the research is changing all the time. So Do monitor the latest research. As I said at the beginning, you're welcome to use this presentation. You can incorporate practical bits into it as well by getting people to do squats and analyze squats as you go along using the techniques here. And finally, that's a list of references which I used for this presentation. Although, as I say, if you want to borrow it, there'll probably be more up-to-date references by the time you use it. Okay, thank you for listening.